Welcome to the Hashimoto's Doctor podcast. You're now part of a growing community of people determined to take their health back through education and self-empowerment. But because of the healthcare system today, we don't have access to the types of healthcare that we want. So we have to do things differently. We've got to do things smarter, and we do that by becoming our own advocates. This podcast will give you the perspective and thoughts of one of the world's leading Hashimoto's doctors. So let's get started. Hi everyone, Dr. Shook here. I hope you're doing well today. In today's podcast, what I want to talk to you about is something called subclinical hypothyroidism. And in case you don't know what subclinical hypothyroidism is, let me first define what is clinical hypothyroidism. What does it mean when you are clinically hypothyroid, when your doctor is going to prescribe a replacement hormone for you? Okay, so let's define what is clinical hypothyroidism first. So that is where you have a high TSH. Okay, so your TSH is elevated, and a low free T4. Okay, free T4 is low. That is considered clinical hypothyroidism. High TSH, low free T4. Okay, that's the definition. So now, why would that be? Think about this for a second. An elevated TSH suggests that the brain is trying to signal the thyroid to make more hormone, because that's what TSH does, right? TSH is thyroid stimulating hormone. So when there's a higher elevation of thyroid stimulating hormone, which is produced by the pituitary gland, a brain-based structure, and that signaling process begins with the central structure in the brain called the hypothalamus, that is kind of like the common pathway between the endocrine system, the nervous system, and even immune regulatory function. Everything kind of is that's the traffic, the traffic control tower is more like the pituitary, but it coordinates everything. Okay, so keep this in mind that this is a stimulating hormone that's job is to activate the thyroid gland and drive it to produce more, primarily produce more T4. So when you're looking to see, well, is the person hypothyroid, the thought process is, if there's a high TSH, the brain is trying to get the thyroid to make more hormone, and if the T4 is low, so they're looking at free T4, which is the more, it's going to be more indicative of a form that's going to be more bioavailable, because total T4 is looking at bound protein. So T4 that's bound to proteins, which is not available for the cells, then that's what the diagnostic criteria is. So that is clinical hypothyroidism. High TSH, low free T4. So that the idea there is the brain is trying to get the thyroid to make more hormone. TSH is high, but the thyroid's not responding and resulting in still having a low T4. So that's going to make them think, okay, the thyroid has an inability to produce the hormone, let's supplement. Okay, does that make sense? Okay, so that's clinical hypothyroidism. Now, subclinical hypothyroidism is different in that there's normal T4 or free T4. Okay, so the hormone level is considered normal according to the lab ranges, right? That the thyroid produces, right? The T4, the free T4 is going to be in the normal range, but there's elevated TSH. Okay, so the TSH is high, which, the thought process behind an elevated TSH is that the brain is signaling the thyroid to produce more hormone. Okay, and we're not talking about pathologies or pituitary tumors or anything else here. We're just talking about everything's functioning normally. We're looking at the feedback mechanisms here throughout the thyroid physiology and the brain. What you're looking at is, with subclinical hypothyroidism, is normal T4, high TSH. Okay, and this is, the issue becomes that a lot of people look at this and they say, well, this is something that shouldn't be supported. There's not a problem. The T4s is fine. The TSH is elevated, but there's normal hormone levels. And I think what we have to do, this is when we have to further say, okay, well, what is optimal? What is optimal thyroid hormone physiology? How can we look at this person and see if, are there symptoms, right? Are there symptoms of hypothyroidism? What kind of problems are they presenting with? might their levels not be optimal enough? Okay, that's I think really important, that we have to look at that, and we have to question what is happening with this person as an individual. And when you start looking at this, more critically, and you say, well, okay, what's the evidence that the body can, or that this person may need like hormone supplementation or for some kind of intervention? And there's an interesting study that came out, and this was actually back in 1995. So this is really important to look at the literature and try to make sense of what's going on and how we might be able to best support people. But there was a study, the incidence of thyroid disorders in the community, a 20-year follow-up of the Wickham study, or the Wickham survey. This was published in Clinical Endocrinology in 1995. So what they found here was that people that have subclinical hypothyroidism, right? Subclinical hypothyroidism, again, is normal thyroid hormone levels, at least normal T4, which is the primary hormone produced by the thyroid, but high TSH, right? So most people are going to say, hey, there's no need for supplementation. The hormones are normal. This is where we have to look again. We have to look at, okay, if it's in the normal range, what is most likely to be an optimal T4 level? Are they optimal? Is that an optimal physiological range? Or are we looking at a suboptimal range that just happens to fall within this broad laboratory range, right? And if you listen to my last podcast, I discussed the TSH myth and I think some of the evidence that suggests that we're probably using too broad of a reference range, okay? And TSH, so anyway, there's some nuances here that I think we have to consider. What is a person presenting with? What are their symptoms? And what they found in this study was that people that had subclinical hypothyroidism, they had a high rate of progression into clinical hypothyroidism. So high TSH, low T4, right? They would progress. They saw that there was a high rate. So it was interesting. They had if the person did not have like a high TPO antibody, okay? So if they had a normal, if they did not have TPO antibodies, which are thyroid peroxidase antibodies, we find those positive in people with Hashimoto's. If those were absent, they had a 2.6% of progression into overt hypothyroidism if they had subclinical hypothyroidism. Okay, so in the absence of thyroid antibodies, if someone was subclinically hypothyroid, high TSH, normal T4, about 2.6 of those people would progress into full-blown hypothyroidism within 1 year, which means high TSH, low T4. Okay, so they're saying this is a sign. This is a sign that these people are headed for hypothyroidism. And there was another group that they looked at if they were subclinically hypothyroid. So again, subclinical hypothyroidism is what? Subclinical hypothyroidism is high TSH, normal T4, right? Normal T4, that's subclinical hypothyroidism. If these people were subclinically hypothyroid and they had TPO antibodies, so they had an autoimmune process that was evident upon testing, that about 4.3% of these people progressed into full-blown hypothyroidism within 1 year. So that this suggests that there is a progression, that this is an earlier stage, and this is something we need to be aware of. And all I can tell you is, like, we're looking at this and we're looking at two numbers in more of an isolated approach here. We're trying to determine, is intervention something that should be considered. And all I've got to tell you is that there are a lot of other ways that the thyroid physiology that can break down, and you need to be looking at all of those. You need to be considering all of those things, because there are a lot more pieces of the puzzle here. But when you're looking at TSH and why TSH may be high, definitely the greatest impact is going to be an influence on TSH levels is going to be your total T4 and your T4 levels, because that is the primary hormone made by the thyroid, and it has the greatest feedback, the greatest influence upon the brain's signaling of the pituitary gland and the production of TSH. So if T4 is high, TSH tends to be low. If the T4 levels are low, TSH tends to be high, and that is the feedback mechanism to the brain. Now there are chemicals, there are other things that can disrupt physiology and create some problems for your thyroid hormone physiology. These are all things that we have to consider, but you know what, you've got to start somewhere. And this is a great place to begin with, just considering, trying to not complicate the variables more than they already are. This is a great place to start. So there's evidence that suggests that we need to consider, intervention, because these people may be headed towards, overt hypothyroidism if they have subclinical hypothyroidism. Okay, so there's also evidence from a few other studies. These studies are, I'm going to go ahead and cite the studies before I give you the evidence here for potentially giving someone like a thyroid hormone replacement when they have subclinical hypothyroidism. So there were two studies done. One was in the Journal of Clinical Endocrinology and Metabolism in February of 2007. The other one was in Thyroid, August 2008. These are very prestigious journals. So there's one of the studies was the effect of levothyroxine replacement on non-high density lipoprotein cholesterol in hypothyroid patients. This study was looking at the effect of levothyroxine. So that is a T4, synthetic T4 thyroid hormone replacement on lipid profiles. And we know that, so clinical, just classic teaching and classic thyroid hormone physiology, you'll learn, almost every doctor learns in school that with hypothyroidism, cholesterol and lipids are going to be elevated, right? That's a classic sign. You see lipids elevated, rule out hypothyroidism. And so this is a study that showed that they were looking at the effects of thyroid hormone replacement therapy, so T4, levothyroxine, on these lipid levels. And so what they found here was that thyroid hormone replacement in people that had subclinical hypothyroidism resulted in decreased total cholesterol. This was non-HDL cholesterol and apolipoprotein B, decreased arterial stiffness, and decreased systolic blood pressure. So it showed that it looks like that there's a positive correlation with at least lipid profiles, which may improve. There's another study done in the Journal of Clinical Endocrinology and Metabolism, 2001, and they said in there that it's possible that treatment of subclinical hypothyroidism, that it does reduce serum cholesterol and has the potential to reduce cardiovascular mortality by up to 31%. So you look at that and you say, okay, wow, this if nothing more than supplementing someone that's subclinically hypothyroid with T4, if nothing more than that, then the benefit of potential benefit of cardiovascular risk, well, that would be huge, because cardiovascular disease is the number one cause of death in the United States. So that could have a huge impact. And so there are a few other studies that suggest that as well. There is one study that suggests that it may not be beneficial. Just to be fair, there's a study that was published in the Cochrane database systematic review, July of 2007, thyroid hormone replacement for subclinical hypothyroidism, and they basically said it was a meta-analysis of 14 randomized clinical trials. They said it did not show significant differences between people that were supplemented and not supplemented, right? So their study says there's some evidence that indicates T4 replacement improves some parameters of lipid profiles. All I can tell you is you've got to look at the people. You've got to look at your levels individually and say, okay, what are they like? Am I optimal? Am I suboptimal? What are my symptoms? And you've got to consider everything. That's my take on it. I mean, I know that's not everyone has the luxury to test every single thing. And look at it and try to take a very comprehensive approach to what's going on and optimize other areas of the physiology and see if they may not, if your other problems that you may be having physiologically may not be contributing to your symptoms of hypothyroidism, rather than just a TSH that's, subclinically elevated, right? So, or subclinical hypothyroidism. And so there's some evidence that suggests that supplementation with T4 hormone replacement may be beneficial in those that are subclinically hypothyroid. So again, high TSH, normal T4. It really comes down to the individual, and I think that you have to look at everything that's going on to best understand, what is most appropriate. And I think when you're looking at prescribing physicians and at their discretion, they have to, they're all concerned about they're all concerned about, what is the guideline, what's reasonable. I don't want to do something that's going to hurt someone, which is absolutely understandable. I mean, of course, that's the top thing. So there are some guidelines, and I think that what really has to be done is that you have to look at at the person as an individual and see if it's appropriate or not for supplementation. You have to look at the different guidelines. So the American College of Physicians, they recommend that people be screened. Women over 50 years old be screened for thyroid disorders every 5 years. The American Academy of Family Physicians believes that adults don't have to be screened until they're over 60. The American Thyroid Association recommends that all adults, men and women, begin their screening at age 35 every 5 years thereafter. The U.S. Preventive Task Force recommends against routine screening for thyroid disease in adults. I mean, it's crazy. I mean, you start looking at it and like no one's on the same page. It's, what do I do? I think that there's a few things that we do know. I think we all believe that the reference ranges are too high. I mean, I think most people that start looking at this more critically are like, well, this is probably someplace where the reference ranges, when we cut out those outliers of the reference ranges, that we find that about 95% fall within 0.4 for TSH, 0.4 to 2.0 to 2.5. So that there's a lower, more tight range that's probably more appropriate. If someone's outside of that, they're probably suboptimal, and there's probably something else going on. What I think is most common is probably Hashimoto's, an autoimmune thyroid process that hasn't been identified. And then suboptimal TSH, which would be something that's probably, along those lines of outside of that 2.5 range, somewhere between 2.5 and up, which would be more suboptimal, is going to be different from person to person. And I mean, that's something that you got to look at, like, what are the signs and symptoms? How's this person presenting? And then, those people are, I think the ones that you have to consider, what are the potential interventions that might be able to help this person. So, my approach is, I don't operate the same way that a lot of other, primary care doctors operate, or endocrinologists. I'm not a primary care doctor. I'm not an endocrinologist. I practice functional medicine. I don't prescribe medications. And what I do though is try to look at everything that I possibly can at one time, so that I can get as clear of a picture as possible, so that we can begin recommending a holistic as possible intervention to help support the person's physiology. And then, if there's a need for medications, then what I do is I refer the person back to their primary care physician with some information in hopes that, or their endocrinologist, in hopes that, they'll look at it and they'll make their decision. And there's a wide variety of opinions and approaches on what is right for the individual. And I think that everyone's trying to do what's best for people. I think it just comes down to, right now not everyone's on the same page. Not everyone agrees on the approach. But I can tell you that I see there are millions and millions of people that are suffering with thyroid-related symptoms, even though their labs look normal or they're subclinically hypothyroid. And whenever we look at them and we start supporting their physiology as many ways as we can, and we try to get them systemically, their entire, looking at inflammatory load and some of these other things that can disrupt thyroid physiology, looking at some of these other issues with conversion issues, are they converting well, and looking at more of the thyroid hormone markers, looking at some of the things that can have an impact on their physiology. I think that's where we start to make big differences without having to even really jump into pharmacological interventions. And that's what I do clinically every day. And I think that's what we have to start. Even if we have a systematic approach, which is really a standardized, more systematic approach, is what needs to be developed for everyday doctors to implement this in practice. I think it would be fantastic if we could look at a few more thyroid-related markers, look at relative ratios of like free T4 to free T3, total T3 to reverse T3, get an idea of whether or not the person is converting properly, get an idea of if they're disconverting more into reverse T3, and understanding some of the factors and vitamins and minerals that play a significant role in those physiological processes. I think we could probably help a lot of people just by having some of those basic things in place. And if nothing else was done, I cast very wide nets. I look at a lot of other things, but those are, when we're looking at thyroid hormone physiology and trying to understand whether or not that's optimal or not, I think that's probably what we need to do, is look at the thyroid hormone, other markers more in a little bit more detail, and look at conversion rates by looking at ratios, comparing like free T4 to free T3, total T3 to reverse T3, looking at your TSH, and really trying to come up with an idea of whether or not your thyroid physiology is optimal. I think that's the best that we're going to be able to do for people. I think that as a very standard, it's something that could be considered a more standardized approach. So anyway, I hope this helps you guys. This was a long one today, but this is, I think, an important one for a lot of people to hear. I think that everyone, and I know that everyone, that your doctors are trying to help you and do the best for you. And when you go in and you share information like I'm sharing with you, they may completely disagree. And you know what? I respect that. I respect that because your doctors are trying to do what is in your best interest. They're trying to protect you. They're trying to do everything that they can. And I think that, everyone's trying to help. So, we've all, there's got to be change on a, on a national level. There's got to be, guidelines that become more specific and give better guidance, so that doctors feel confident in making in ordering some of the tests for you, in potentially, recommending a thyroid hormone replacement. That there are guidelines and there are standards that they're trying to uphold, and they want to do what's best for you, and that's what guidelines are. They're an attempt to do what's best for you. I think that we could do a little bit better. I mean, that's just my opinion on it. But anyway, I want to share this with you. I think this is a really important topic. I hope this has helped you guys out. Remember, it's always my mission is to help you to better understand and be your own advocate. Because if we can help you, if I can help you improve your health, that's going to have a positive impact on your family. That's going to change your community. And ultimately, I think that's going to have a positive impact on the world, one person at a time. And I want you guys to be your own advocates. I want, not an adversary, but an advocate. I want you to be better partners with your healthcare providers. I want you to be active participants in your healthcare. I think that's a really important thing that we've got to do. And if we can do that, then we can really improve, the health of our communities and our world, just by being more involved, asking better questions, and trying to understand our health a little bit better. So anyway, I appreciate you guys. I hope you have a wonderful, wonderful day. I'll talk to you again very, very soon. I appreciate you hanging out. Thanks. Thanks so much for listening. We hope you enjoyed hanging out behind the scenes with Dr. Shook. You can also talk with and learn from Dr. Shook through Facebook Live on our Facebook page at the Office of Dr. Brad Shook. Don't forget, you can also get access to our videos, guidebooks, and thyroid programs at www.drbradshook.com. Oh yeah, and don't forget one more thing. We can change the world one person, one family, and one community at a time. Until next time, remember, today is your day, and no one will tell you who you are and what you can be.